Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me. This patient had a dislocated single piece acrylic lens, as well as a dead bag situation and a Summerings ring. But this is a highlight of this case. As I tried to execute cannulation of the trailing haptic through the right side needle, I lose the trailing haptic into the vitreous space. And so with my modified technique, how was I able to recover from that? By losing the trailing haptic into the vitreous space, it was dangling in that space. What did I do to recover from it? And why did my technique allow me a competitive advantage so I didn't run into any further trouble with this case? As you can see here, this is a slit lamp examination of this patient. You can see that the lens is clearly not well centered. You can see the haptic as well within the pupillary opening. You can see there's virtually very little capsule that's visible in this case. It's almost invisible. There's no lens material as well. It's just an empty clear bag and this lens that's really rather unstable within that bag, sitting dislocated. And so this is a patient under the microscope. Again, you can see that the lens at least has some level of support because it's not falling posteriorly. And in my experience, these patients tend to have liquefied vitreous as well. And so you can see here, there's no vitreous in the anterior chamber as well. And so again, this is just a late dislocation, not a complicated cataract surgery situation. Again, if you've had complicated cataract surgery, you can have corneal damage, you can have vitreous in the anterior chamber. Those cases, I think there's a bit higher risk. Corneal pathology, macular edema, and retinal problems as well. But in my experience with these come out fairly easy, again, without very much vitreous entanglement in this situation. This is a fixed caliper from Epsilon, 2.5 millimeters posterior to the limbus I'm marking, and then 2 millimeters adjacent. I like to make the indentation and then mark it with the tip of the cannula. By doing it this way, you get a more discrete mark. So I first do that on the right side, and then on the left side, indenting in radial fashion, 2.5 millimeters posterior to the limbus, and then 2 millimeters adjacent. You have to use a Wexel sponge as you dry the surface. If you don't use a Wexel sponge, you're going to get bleeding of the ink. And for the trocar placement, you have to switch from the Wexel to the sponge. So the cotton tip is much better at holding the eye. The Wexel is much better at drying the eye. So I'm going to tunnel about 2 to 3 millimeters from that mark, tunneling to the other mark as I tunnel, and then rotate perpendicular to the scleral surface, and then withdraw the needle. You can see that this is going to be a self-sealing incision because the trocar is sitting sideways. I go ahead and make my incisions. Those incisions are going to help me take the lens out. This is the incision for my AC maintainer. And then this is the incision for externalizing the leading haptic, the new lens haptic through the contralateral limbal incision. Again, this is for the trailing haptic first technique of my modified Yamane technique. This is some intracameral epinephrine first. And this is some dispersive viscoelastic to coat the corneal endothelium, and also just to push back any potential vitreous that might be in the anterior chamber. And this is the 3 millimeter keratome incision. I make a vertical groove, tunnel, and then I enter. Go ahead and grab the lens, lifting it up, and then grabbing it on the other side, and then just repositioning with my hand just to get a better grip using 2 microforceps. And then using the scissors to the main incision, I'm making sure the leading haptic is in the anterior chamber before I do this part, because you have to have both haptics in the anterior chamber and the angle. Cut the lens completely in half with the scissors. But you see I left just a little bit of a tag. I didn't cut all the way through. And then using microforceps, switching from the scissor to the forceps, I'm going to go ahead and re-grab. I'm going to go ahead and pull the left side piece. See that I let the lens bend backwards away from the cornea while holding the left side. By doing it this way, I minimize any corneal damage, but I'm also able to hold the lens and secure it. I turn the left side piece 180 degrees so that the haptic comes out straight, and I pull it out. And these are the Ogawa 22 gauge large bore AC maintainer. This is a phenomenal AC maintainer. I'm able to get good infusion pressure through this AC maintainer while being able to place it through a small incision. This fits through a typical 1 millimeter paracentesis incision, unlike the 20 gauge Lewicki AC maintainer, which you have to widen those incisions, and invariably in my experience those tend to leak, and then I have to suture those incisions. Very annoying. So I don't ever use that one anymore. I use this one now. So I place the AC maintainer first and turn on infusion. I'm able to burp that Summerings ring. So that's the easiest way to get rid of that Summerings ring. Otherwise, if you try to grab it or cut it, you might lose those pieces into the vitreous space. But by turning on infusion and then burping the incision, you're able to very easily get that piece out because the wound is a path of least resistance. But unfortunately, I do that and I turn on the infusion, I do have a little bit of vitreous coming to the wound. Go ahead and place a Weck over that area, and without adding any more traction, I go ahead and amputate it with a scissor. Again, just a little bit of vitreous, not a whole lot. In my experience in these cases where the lens is dislocating, they're dislocating because the vitreous is liquefied. And so that's part of the pathology that's going on. So the liquefied vitreous, there's reduced support for the lens and the lens collapses. And so again, not as high risk to the retina in my experience. Again, I've done hundreds of these cases, and knock on wood, I have not encountered a retinal detachment or retinal tear by performing these surgeries. And I think it goes back to what I was saying. In these cases where there's late spontaneous dislocation, it's due to the vitreous liquefying and reducing that support of the lens. Again, this is different from if a patient had a complication during cataract surgery and then had dislocation. That's a different scenario. In those cases of primary cataract surgery, there is very strong and firm vitreous, and in that case, I think there's a much higher risk for retinal detachment and retinal tears. But in these cases, when there's late spontaneous lens dislocation, in my experience at least, they don't tend to cause those types of retinal complications. But again, of course, you never know in these cases. So very carefully just making sure that there's no vitreous to the wound. I'm just using the vitrector, making sure that there's no vitreous there. So I'm doing some more vitrectomy, making sure there's no vitreous to the wound. And now that I'm done with that, I'm going to go ahead and bend my needles. This is the 30 gauge thin walled needle. The right side needle, I'm bending it about 9 millimeters from the tip, and I'm bending it in such a way as I hold the syringe that the bevel is going to face towards me. On the left side, I bend it at the hub, and as I'm holding the syringe, I make sure that the bevel is facing away from me. This is a 25 gauge needle. I bend it fairly close to the tip, and I want to bend it about 80 degrees and making sure the bevel is facing to the right. So attention is drawn to the lens. The cartridge has already been filled with cohesive viscoelastic. I make sure the sensor lens is seated within the cartridge. I'm bending the wings together. You want to make sure that the leading haptic goes straight into the barrel and the trailing haptic comes out from the back end. You want to place the cartridge into the injector, making sure the trailing haptic is up and out from the barrel, and you advance the lens. The 25 gauge needle is in the contralateral limbal incision. I advance the lens, turning the bevel to the left. My assistant starts to advance the lens. I make sure that the leading haptic is aligned with the 25 gauge needle, dock the haptic on the bevel of the needle. She advances the lens so that the haptic keeps going further and further into the needle. I withdraw the needle and the haptic comes out. I take over, deliver the optic, and then deliver the trailing haptic, making sure the trailing haptic is faced towards the right. I want to give it time, make sure the optic opens up completely first before you do anything else. Push some more dispersive viscoelastic to push the optic back. And now this is the scleral needle placement. So again, 30 gauge thin wall needle from the first mark, holding the incision, making sure the eye is in the neutral position, stabbing the needle into the sclera from the first mark, tunneling, staying nice and flat, tunneling through the sclera, going to the second mark, diving down, making sure infusion is on the entire time as you do this. By having the infusion on, the eye is firm and it gives you better control to be able to make sure you precisely tunnel the needle to the sclera from the first mark to the second mark. And then very carefully, using microforceps, I grab the haptic and I slide it into the anterior chamber. I want to dock the haptic on the bevel of the needle and then sliding it in. So again, very carefully, I'm sliding the haptic into the needle. And again, if it doesn't go in, you don't force it. You just realign, readjust, very nuanced, very subtle maneuvers to align the haptic and the needle. And again, sometimes people just try to jam it in with the forceps, but what it requires is a subtle repositioning with your right hand with the needle. And so that's kind of those tips of the trade as you've done more of these. People fixate on the left hand and they just try to shove the haptic. That's not what you do. You have to reposition the needle so that it presents itself in such a way that the haptic wants to go into the needle. So after all those maneuvers, you see I'm having a little bit of trouble. I'm trying to reposition. And you can see here, I'm doing the best that I can, but it's not going in. I'm really having a lot of trouble. And so what is it? Is it because the haptic is wrong, that the needle is wrong? What's going on? Most likely because my angle is wrong. And so I'm doing the best that I can. And then look here. See here, I lost the grip of the haptic. So I stop, I take the needle out, and I ask myself, is it because the haptic doesn't fit in the needle? And I'm making sure that I very carefully lift that trailing haptic up. This is a nice thing about this technique. See, I have that leading haptic out of the eye, which secures the lens, and I had no worries that the lens was going to be lost. This is an excellent example as to why I do it this way. I use a two-handed technique and very carefully re-grasp the trailing haptic and externalize it. You saw how very carefully and delicately I took that trailing haptic out using two forceps. And then I go ahead and test it. So this is that same needle and it goes in super easy. And so obviously it's not because there's a mismatch between the haptic and the needle. There was a mismatch in my angle. So it's really an execution issue. So I go ahead and start over. Infusion is on. Grab the incision. Keep the eye in the neutral position. Stab the sclera at the first mark. Tunnel. Stay flat. And then dive down at the second mark. I make sure I get a nice scleral shelf for my haptic, doing it this way, sliding the haptic sideways so it doesn't bend the haptic. Again, very gentle touch. Docking the haptic on the bevel of the needle, and look, immediately it goes in. And so again, that took no effort, but you saw how it takes patience, and sometimes it doesn't go the way you want to, but you have to have patience. And again, because I was able to have the leading haptic externalized, you saw that I did not lose the lens. A great example as to why this technique works so well. Disengage the syringe from the needle, internalize the leading haptic with microforceps and placing it within the angle. Performing the same maneuver on the left side, holding the incision, turn on the infusion, make the globe nice and firm. Hold the eye in the neutral position, stab the sclera from the first mark, tunnel through the sclera to the second mark, and then I dive down. Rotate the needle tip so it's in view. grasping the leading haptic with microforceps, docking the haptic on the bevel of the needle. Once you dock it, you can re-grasp it, and then it goes right in. Very quick. That one is such a quick one on the left side because it's easy to see because it's away from you. Pull the left needle towards me, right needle away from me. As I withdraw that left side needle, make sure the microforceps is there to grab the haptic, and then you cauterize the tip. Switch hands, do the same thing on the other side. Pull the needle with the right hand away from me, making sure the micro graspers are ready to hold the haptic, but also making sure not too much of the haptic comes out, cauterizing the tip. And that's it. You can see how beautifully flat the haptics are right here. This means I had an excellent scleral tunnel as I executed the needle piercing through the sclera. You can see the optic is in perfect position just underneath iris plane. As a result, this is going to have an excellent refractive outcome with the patient. There's no tilting. There's no distortion. Again, if you have a vertical position of the haptic, that is called the flagpole sign, which means you have an inadequate scleral shelf, which will result in a poor refractive outcome and optic tilt. Go ahead and perform my vitrector assisted PI with the port down, make a tiny little PI temporally. Place a 10-0 Allen suture through the main incision. Now going back to that trailing haptic, needle, the right side needle in good position. I bent the needle properly. I grabbed the haptic very gently, didn't bend it. And for some reason, I could not cannulate the needle. I just couldn't. I could not cannulate the needle. And then you saw I kind of let it drop and it fell into the vitreous space. But because the leading haptic was externalized, the lens didn't go anywhere. I was able to use two forceps to grab the optic and the haptic and just inch it little by little by little, inch it with a two-handed handshake technique. And then I was able to externalize the trailing haptic. I tested the needle and haptic to make sure it actually cannulated, which it did very easily. So I knew it wasn't because it was a mismatch. It was because I didn't properly execute it. Again, for whatever reason, I had trouble with the angle. It was presenting in a funny way. But, that's part of the surgery. You have to learn to adapt and know what to do. And so I go ahead and start over. And immediately I was able to cannulate the haptic through the needle. You got a perfect lens location. This is, again, put a 10-0 Allen suture in. I pulled the trocar out, massaged the incision, turn on an infusion. There was no ballooning of the conj. Took the AC maintainer out. Again, because of this 22 gauge, smaller size AC maintainer, but large bore cannula, it allows higher infusion pressures. It's such a great AC maintainer. This is the only one I use. I don't use a 20 gauge anymore. I use this 22 gauge Ogawa AC maintainer. Go ahead and place the fluorescein strip over the eye. Make sure all the incisions are nice and sealed. And that is the end of the case. So again, this patient had a dislocated single piece acrylic lens, dead bag situation. Again, in these cases, the vitreous has essentially liquefied, very little vitreous presenting in the anterior chamber. Went ahead and used two-handed technique to grasp the lens up into the anterior chamber, bisected it in half, but not all the way. I just bisected about 95% of it. As I pulled out the right side piece, I made sure that the attached part of the lens bent backward towards the vitreous so it wasn't going to hit the cornea. And as I pulled it, it basically cut it off. But since I was holding it with the forceps in my left hand, I had it nice and secure. I grasped it with the right hand forceps and rotated it 180 degrees so that the left side haptic, the leading haptic, would present itself in a less traumatic manner. And then I was able to pull the lens out, protecting the corneal endothelium. And again, you saw how I struggled to cannulate that trailing haptic. And that's the point. Even though you have a lot of experience, sometimes that happens. But by understanding the technique, understanding what you're doing, you can be calm, re-attempt the execution of the surgery, and this patient did very, very well. So I hope this was helpful to you, and I thank you for your attention.